So unfortunately, um, each slideshow needs its separate recording. So now we'll go on to chapter 9, working with an individual patient. The objectives for this lesson is to describe the meaning of being therapeutic, describe the stages of a therapeutic nurse-patient relationship, apply the nursing process to psychiatric nursing practice, and identify the components of the mental health examination. We'll also describe the importance of a specific nursing diagnosis and care plan, and as well as understand the importance of charting, discharge planning, and process recording. So, therapeutic relationships is when the nurse offers her presence and engages in a relationship to support the patient's challenges and recognize their unique strengths. The nurse would use caring to promote patients' growth. We use collaboration in patients have a right to make their own decisions about their care. So you need to recognize the problem. They need to show desire to change, asking for assistance or help, and collaboration between the nurse and the patient is most effective and an enduring method to promote change. Coercion is not effective form of therapeutic communication. Social versus therapeutic relationships. Therapeutic relationships are established and maintained through objectivity and goal-directed discussions and activities. The patients can misinterpret your interest. You need to remind the patient of your role and the need for friendship, love, and support, and maintaining the role as a nurse is paramount. Nurse's basic education, which is your knowledge and skills for a therapeutic relationship. Your advanced practice nurses provide therapy in formalized ongoing sessions that are process-oriented. The therapeutic relationship takes place to assist in discussing problems and practical solutions in a brief encounter. Therapeutic relationships provide validation and feedback. Being therapeutic versus providing therapy. So informal or recreational encounters gives you the opportunity to observe inappropriate social behaviors and provide opportunities to demonstrate ways of handling situations. Brief therapeutic relationships are planned, patient-centered, and goal-oriented. Sharing personal information can involve sharing your age, your marital status, your title, but rarely personal problems. Brief self-disclosure would help patients clarify their specific needs. It would facilitate comfort, provide honesty, provide openness, involves risk-taking, and it never burdens the patient but you never burden the patient with your own problems. So first case study here is Marilyn has just learned that her husband of 10 years is thinking about a separation. She is sad, has not been able to sleep, and is slightly irritable. While listening to reports, she says a negative comment about a patient who was admitted overnight owing to a suicide attempt. The patient has just told her husband he was planning to leave her. How will Marilyn's current marital problems affect the care for the newly admitted patient? And what steps can Marilyn maintain, or what steps can she take to maintain therapeutic relations with the newly admitted patient? So let's think about this for a minute. So what Marilyn should do is she should request not to be the nurse in charge of this patient's care during her hospitalization because her own personal issues are so recent and that, being that she just learned of her husband's plan for a separation. So while on the unit, she should remain therapeutic and pleasant toward the new patient. And during the hospitalization, she should not run problem-solving groups that explore marital issues. Nurses who are dealing with their own personal issues should not utilize the therapeutic milieu to discuss or work on their own issues. So stages of development of a therapeutic relationship. Peplow's stage of orientation is that the patient recognizes needs and seeks help. The nurse helps the patient understand the problems and would provide available help to foster trust and developing the relationship. Identification and exploration stage, or the working stage, is where clarification of the perceptions and expectations about the relationship is identified, and the problems and identification of the tentative solutions are further defined. The resolution stage or termination phase focuses on the growth and on helping the patient develop self-responsibility for setting new goals. The entire relationship is viewed by Peplow for promoting growth and a learning experience for the nurse and the patient. So a little bit more about stage 1, or the orientation phase. This is where the nurse learns about the patient and his or her initial concerns or needs, and the patient learns about the role of the nurse. There is identification of the problems that they will be working on, and then the nurse collaborates with the patient to define a specific area to pursue. The nurse then helps the patient to look at realistic options so that the patient can make his or her own decisions. When we talk about building trust, the nurse needs to be honest, consistent, and show mutual respect. They need to follow through on their actions, so they need to do what they say they're going to do. They need to explain confidentiality or HIPAA regulations, as well as reach out in non-confrontational ways. During this stage, you're also managing your emotions, you're providing emotional support, and you're also providing structure. Stage 2, or the working phase, is where the patient's ready to work towards changing his or her thoughts, their feelings, or their behavior. It's where stabilization with their medications occurs, a reduction in their symptoms occurs, and development of supportive relationships are valid goals. When we talk about in-depth data collection, this is where you facilitate awareness, analysis, interpretation through in-depth but selective exploration of issues and identification of priority issues. Focusing on too many problems may be overwhelming to the patients, so you need to make sure the focus is manageable and changeable, and the issues are able to be changed. To promote change, you use motivational interviewing, which is patient-centered. So you want to ask open-ended questions, use reflective listening, and also validation. Ambivalence is important to explore because lasting change cannot occur until the patient endorses the necessity for the change. And you also need to express empathy, roll with resistance, and support self-efficacy. The stages of change process there's 5 steps. So you have pre-contemplation, where there's no plan to change the behavior and they don't recognize that they have a problem. Then you have contemplation, where they identify a problem and think about their actions, and ambivalence is a predominant feeling. The third stage is preparation, where they're imminently ready to work on the change. And then action is where they actually initiate the change. And then maintenance is where their goals are met and they avoid relapse. So the second case study is Alfonso has been admitted to the behavioral care unit after expressing feelings of wanting to end his life. He was terminated from his job for arriving intoxicated at the job site. He has been drinking heavily for the last 2 months, and the supervisor had tried to intervene and suggested that he go to Alcoholics Anonymous. So using the 5 stages of the change process, what stage is Alfonso exhibiting? Pre-contemplation, contemplation, preparation, or action? So here he's exhibiting the pre-contemplation because he did recognize that he has a problem and admitted himself to the hospital. He hasn't admitted he has a problem. So his nurse, using therapeutic relationship and motivational interview, assists him to identify his problems as well as helping him to understand his problems by asking in-depth, detailed descriptions of the situation's thoughts, feelings, and behaviors. The third stage is the termination stage. This is where you evaluate and summarize their progress. You synthesize the outcomes. You make referrals as they're needed. And you also discuss the termination of the relationship. So now we'll talk about interactions with selective behaviors. So when you're dealing with a patient that has violent behaviors, you want to stay out of their striking zone or stay within outside of their striking distance. You want to avoid touching them without their approval. Changing the topic if the behavior escalates. So you're trying to distract them. You could suggest a timeout that has less stimulation. You want to avoid entering a room alone when the patient is out of control. You would leave the area temporarily if the patient's agitated and is asking to be left alone, or you can call for assistance if a patient is losing control. When you have a patient that's experiencing hallucinations, you want to comment on their behavior. If they acknowledge hearing something, the nurse can ask for more information. You would assess the hallucination if the hallucinations have themes or themes of powerlessness, hatred, guilt, or loneliness. After the content is known, you want to focus on the hallucinations as being unnecessary. So don't focus on their hallucinations. Don't put your focus on that. You want to distract the patient and teach the patient to distract themselves from the hallucinations. When you're dealing with delusions, you would want to have them clarify their meanings. Don't argue with them about the delusions. It may strengthen their belief in them. You want to monitor their behavior to prevent harm to themselves or others. And for patients with dementia or severe cognitive impairment, with those types of conditions, ignoring or providing distraction may be more effective. When you have conflicting values, you want to understand the patient's point of view as they see it. You want to encourage them to examine the effect of or outcomes of their beliefs on their lives. And you also want to provide supportive confrontation to assist them to examine the effect of their maladaptive behavior on their lives. So when you're dealing with severe anxiety and incoherent speech patterns, you want to try and clarify the meaning of their communication. You want to key into their feelings and their underlying themes rather than try and make sense of their incoherent speech. You also want to spend frequent and brief time intervals to offer support and build trust. When you're dealing with somebody who's manipulative, you want to address what is happening or had happened in the nurse-patient relationship. You want to use limit setting. Power struggles are useless. You also want to help patients express their needs directly. When you have a patient that's crying, you could allow and encourage them to verbally and non-verbally express themselves. Realize that crying can relieve their tension. You want to provide them with privacy. You should be quiet and unobtrusive. And you want to encourage the discussion of the circumstances that precipitated the crying. When you have a patient that is making sexual innuendos or inappropriately touching you, you want to immediately ask the patient to stop that behavior. You want to remind them that the actions are inappropriate. You could also discuss the underlying need. Be sure to set limits. The nurse should refrain from touching the patient with sexual and boundary issues because they may misinterpret your touching. And the nurse is responsible for maintaining the professional barriers. If you have a patient that refuses treatment, you want to listen, you want to clarify. You also want to encourage verbalizing their thoughts to identify the underlying cause for the lack of cooperation. You would want to discuss the causes, the fears, and the outcomes of the patient's behavior. And then the nurse's role is to use therapeutic communication to increase trust, which may lead them to be more agreeable to treatment. So we're back to Alfonso, and he's asked to participate in the community group meeting on the first day of admission to the inpatient unit. He attends the meeting but does not want to contribute by setting a short-term goal. I don't need to learn goal setting. I need to be discharged. So how should the nurse respond to Alfonso's refusal to participate and accept treatment? Would you say drinking costs you your job? You need to explore that prior to discharge. Would you say, can you think about how the hospitalization can help you prior to discharge? Could you say, if you're not motivated, why did you come to the hospital in the first place? Or could you say, this is a place for people to set goals that are achievable in an 8-hour day? So the correct answer, of course, is B. Your role is to listen and clarify collaboratively with the patient to assist him to utilize the hospitalization for problem solving, even though he has decided to request discharge. If you choice A is too confrontational, and they may not be ready to explore the link between his drinking and the loss of his job. And C is not helpful at all. And D restates the purpose of the meeting, but ignores the patient's thoughts about goal setting. To continue on with interacting with certain behaviors, if you have a patient with a depressed affect, if they're displaying apathy and psychomotor retardation, you want to use patience, use frequent contact and empathy to assist the patient to recognize the need for change. The patient may not have a lot of energy, so you want to make the change quickly. And know that improvement in their personal hygiene, proper nutrition, and gradual increase in activities is encouraged. If you have a patient that is suspicious, you want to communicate clearly, simply, and congruently. You want to clarify any misinterpretations that they may have. You would offer the rationale for rules, activities, occurrences, and noises. You would encourage participation in their treatment and don't force patients to participate. And if you have somebody that's displaying hyperactivity, that could be upsetting to other patients, to staff, and to that patient. They can unintentionally harm themselves or others. So you would want to place them in a quiet area with minimal auditory or visual stimulation. You need to remain calm, speak slowly and softly with them. You want to respect their personal space and offer PRN medications as needed. So when we're talking about assessing the patient, you would want to gather demographic information, admission information, the reason for admission, any previous psychiatric history, any current medical problems, as well as medical medications, if they have any drug, alcohol use or abuse, if they have a disturbance in their patterns of daily living, if they have any cultural or spiritual needs, and also the level of support that they have in the outside. When we talk about the mental status examination, that's their current state of their thoughts, feelings, and behaviors. It assesses their general appearance, their behavior during the interview. You're evaluating their social skills, their motor activity, and their speech patterns. You're also assessing their concentration and attention span, their orientation, their memory, their intellectual function, their affect, their mood, their thought clarity, and their thought content, as well as their thought processes, their insight, their judgment, their motivation. And then if a patient is too ill to complete the assessment, you would assess anxiety level, degree of withdrawal, their thought disturbances, and their general appearance. Part of the ongoing assessment is the context or situation that precipitated the behavior, their thoughts at the current time, their feelings then and now, their behavior in the context, their behavior adaptive or dysfunctional, how the current episodes fits with the total picture of the patient, and is the change needed, and their current mental status examination. So some nursing diagnoses would be risk for actual problems, contributing causative or ideological factors. You would define characteristics or behavioral outcome, and they don't include any medical diagnoses though. Outcome identification. So you want to be specific in the adaptive behaviors or replace the dysfunctional behaviors. The goal needs to be achievable and measurable. You want to determine short-term realistic goals and collaborate with the patient to determine realistic goals. When we talk about planning and intervention, this is where you're going to develop your nursing care plans. It would begin with one or two behavioral-oriented problems such as suicide, aggression, arson, escape, withdrawal or isolation, delusions or hallucinations, impulsive behavior. You want to identify the problem, the outcome, the time constraint, and any related nursing interventions. And when you're talking about interventions, you want to keep in mind that the patient's their unique problems and their needs. When you're documenting in progress notes, either written or electronic, you want to include what statements the patient would make, what your observations were, your analysis, and your plans. You want to ensure continuity of care, and you also want to evaluate the effectiveness of any treatment plans that you were part of during your shift. Shift reports should be concise, focused, and include an abbreviated list of the items that were included in your progress notes. Your progress notes needs to include subjective data, objective data, analysis and conclusion, or plan. And that's where you get your SOAP, your subjective, your objective, your analysis, and your plan. Evaluation, that's where you're going to evaluate the progress on their goal. If you're expecting too much change too soon, you need to reassess and revise the goals. Evaluation also determines the needs for patient referrals. Your discharge summary, you need to identify the outcomes that the patient has achieved. You need to identify the outcomes that still must be addressed. Their medications, which would include the dosage and times, any follow-up appointments, that includes the dates and the times, any referrals, and also the patient's ability to read and understand the discharge instructions. And finally, process recordings. These are used to show application of concepts and examples of interventions. They would assess and analyze communication skills. They identify patient themes. They evaluate the effectiveness of the interventions. Their verbatim record of the encounter with a patient. And they're also verbal and nonverbal behaviors of the patient and the nurse.